Hi, Mike Gibson here, talking about the future of stroke prevention. Well, what's in the pipeline? Several things. There are drugs you may have heard about, the factor 11 inhibitors, drugs like asundexian, milvexian. These drugs are being studied in phase 3 along with abelacimab. There are monoclonal antibodies like abelacimab, once a month dosing, long half-life, but yet safe to perform a procedure on. There are some new drugs coming along that are a little more reversible and have lower renal clearance. And finally, the goal of all of this, though, is to keep people from falling off the balance beam, either having a bleeding event or an ischemic event. We want to keep them on the straight and narrow and not having either of those events. And maybe this class offers that possibility. There are 3 different horses in the race right now. Abelacimab, this is an antibody, once a month dosing, given subcutaneously, being studied in the atrial fibrillation patients and also in people who've had venous thromboembolism who have cancer. So a treatment strategy in cancer patients. There's asundexian, a small molecule that is being studied right now in post-stroke patients in phase 3. And then there's milvexian, a small molecule factor 11 inhibitor being studied in AF, post-stroke for secondary prevention, and post-ACS for secondary prevention. You're looking at nearly 50,000 patients being studied there in phase 3 programs that should end up in somewhere around 2026, 2027. So what are unmet needs and how are we trying to address that? We've seen that docs and patients want to avoid bleeding, fairly risk adverse to that side effect. Stroke, ischemic stroke, heart attack, those they don't think about that. No one comes to your office saying, thank you for preventing a stroke or heart attack. They come to your office saying, you know what, I've had some bleeding and I'm concerned about it. So there's asymmetric warfare between a complication that you don't see, that you're preventing, versus a side effect that is very overt and manifest. The other thing we want to do is convenient dosing. We want to have drugs that may match the preferences of the patient once a dose, subcutaneously, for instance. And, we got to make sure that we are taking into account the patient's metabolism. Is it going to work well with their kidneys, with their liver? And is it going to play well with all the other drugs that they're on in terms of drug-drug interactions? There's going to be some new tools out there. There are going to be some RNA-based strategies that rather than inhibiting the factor that's floating around, they'll turn down the production of that factor. So there's 2 ways to think about it. If the sink is overflowing, are you going to mop the floor up? That's kind of what we're doing with some drugs where we have the antibodies, small molecules targeting the factor, or are you going to turn off the production? That's kind of turning off the sink. And some of the new strategies will turn off production, turn off the sink. So given our interest in novel targets beyond factor 11 and the momentum that we have for personalized treatment, how do you see our stroke prevention strategies changing over the next 5 to 10 years? I look forward to a world where we're going to have more and more personalized medicine. I think we do trials in populations, but we treat patients. We're going to be gathering more and more data and using better decision-making tools to help guide that decision-making over the next 5 to 10 years. I think we're going to incorporate patient preference into those decision-making tools. I think we're going to incorporate what we know about PK drug levels and PD, the effect of the drug on the body, into that decision-making. So I think you're going to bring together patient preference, biomarkers, AI and tools to look at all the risk factors together to really improve our decision making in these patients. One size does not fit all. Certainly, our genes drive some of this, and there's more and more information out there about your genetic risk. I think there's also a lot of information out there about the exposome, what you're exposed to, like other drugs, and how that's going to modify your risk. And finally, there's other things with respect to patient preference that the patient's going to want to dictate. So all those will come together. So when we talk about patient monitoring, are we incorporating wearables and other remote devices to look at adherence into practice yet? Not yet. I'm leading a trial where we randomized 34,000 people to an Apple Watch or not to see, can we detect new onset atrial fibrillation? We'll see what we see there. Currently, a lot of these wearables are consumer grade. They're not medical grade. They're being used as tools for screening, but your doctor's still going to have to make the diagnosis. So I think we're on the verge of seeing, in large scale data, can we detect these kinds of arrhythmias with a consumer grade device? And then secondly, does that improve outcomes? So the first thing is diagnosis. The second thing, though, is treatment. Will some of our digital tools also improve adherence and compliance? So what are some of the technology-driven approaches to this? I discussed wearables like an Apple Watch or patches. Rather than having a doctor think of the risk score in their head, can we incorporate those into the electronic medical record? I think we're making improvements there. We are making improvements in tracking adherence, pill boxes that record whether someone actually took their pill or not are out there. There's all kinds of digital programs on apps to improve compliance. So all of this is being integrated more and more into clinical workflow. Now, use of the watches and wearables is growing. We'll see if they really do the job in terms of diagnosis. I think patient engagement is probably one of the most important things we can do. It's not just about evidence-based medicine, it's relationship-based medicine and improving our relationships with patients and their caregivers. We're doing a lot to try and improve the technology of the wearables to distinguish all these different rhythms. But again, they are screening tools right now. And again, the diagnosis will rest with the treating physician. So there are going to be innovations ahead. We're going to have new factor 11 kinds of mechanisms. Like I said, turning off the sink by turning down the production of the factors. We're going to see whether these drugs are effective in maintaining effectiveness, not just reducing bleeding. I do think we're going to see more and more in the way of precision medicine tools coming along, but bringing all this together, bringing together our new drugs, our new diagnostics, our new decision algorithms, and our new approach to integrating patient preferences is going to be the future. So we've explored the future of AF management, including genomics, predictive modeling. How prepared do you feel to integrate these tools into your care that would help bridge the gaps that we have? I think doctors are tired of working for technology. We need technology to work for doctors. I think as more of this gets streamlined, as more of it gets integrated into the background of providing care, into electronic medical record, et cetera, I think that will hopefully drive greater adoption of some of these tools. The tools have to work for the patient. The tools have to work for us. We can't work for the tools. I think people are a little burned out in some of this. So in conclusion, I think we have a novel approach here with factor 11 inhibition. Looks like it's safe. Let's see if it's going to be effective in some of our ongoing trial. I think bleeding is something that causes a lot of pushback on the part of docs. They're risk adverse. Patients are risk adverse. It's one of the reasons patients stop medicines, even if it's minimal bleeding or minor bleeding. We have a lot of elderly people. We have a lot of people with bad kidneys, and they're going to be at higher risk of bleeding. We're waiting to see if we can maintain effectiveness. Hopefully, we'll have some tools that we can integrate into practice to help us guide shared decision making and make sure we're giving the right dose of the right drug to the right patient at the right time. So it's up to you. What are you thinking about out there? And what are you considering to change in your practice after we've had this discussion? Well, I want to wrap up by saying a few words about getting credit. You can return to the activity page called Talking Stroke Prevention, Rethinking Stroke Prevention, Addressing the Unmet Needs in Antithrombotic Therapy. You can go to practicepointcme.com, click on the Claim Credit button associated with this individual archived presentation. Complete the post-test and evaluation form. We will make sure you've learned something. And once you complete that post-test with 80% accuracy, you'll get your certificate mailed to you. Your APCE credit or ACPE credit will be submitted to Rush University and posted on the CPE monitor. If you're seeking ACPE credit, the completed evaluation must be received within 30 days of the activity. So again, please visit us at Practice Point CME to review other archived presentations of interest and receive additional accredited continuing medical education. Thanks for joining us.